Hi, we're Nia and Mary-Anne from Health Coaching. We are metabolic health coaches who are passionate about good metabolic health for everyone. We also love to chat about all things health and to share as much information as we can with people who want to make changes to their lifestyle but aren't quite sure where to start. We're going to release a new episode every fortnight on Fridays where we talk about a different aspect of health. So do subscribe and let us know what you think. We'd also love to know what you're interested in too, so if there's something you'd like us to have a chat about, do send us a message and we'll do our best to cover it soon. Do check us out at our website www.serenhealthcoaching.co.uk or find us on Instagram at serenhealthcoaching.
Good morning. Happy
How are
New
you?
Year and all
Oh,
that.
Happy New Year to you.
You know we don't do New Year's resolutions, you and I, but
No.
as we've discussed on a podcast previously, but
Mm-hmm.
it is a good time, I think, for a bit of reflection all the same.
Mm.
And I was looking back through all our podcasts. I was always staggered at how much we've done.
Yeah.
Um, but I thought maybe New Year and a quick
Yeah.
recap on
Awesome.
how it all began for us, and how finding out about this thing called insulin resistance really changed our understanding of metabolic disease
Mm.
and made us question conventional clinical practices. And I know that you actually were taught in your course all about insulin resistance. I wasn't, of course, so I had absolutely no clue that it
Yeah.
wasn't as they had told me, which was all
Yeah.
about high blood sugars. But anyway, this knowledge has given us a unique understanding, I think, of how these new weight loss drugs are going to
Work.
work too. And I think they may prove not to be the answer to all our metabolic problems. So we're going to do this in two parts. So today it's all about, let's just recap where we got to and how the principles that helped us to understand hunger
Mm-hmm.
and how your diet and activity levels, including that lean muscle mass, affect your health.
Yep.
And in part two, which will be much more to do with you,
Okay.
we'll talk more about how this led to the development of these new weight loss drugs and
Yeah.
the implications of these, particularly around the effective use of them,
Mm.
titration, and implications for weaning or long term use.
Yeah. We think anyway, and certainly seems to be the case, that if we need to understand weight and blood sugars, more than anything else, you need to understand insulin
Yeah.
resistance, which doesn't sound like the most riveting topic
No,
in the
it
world.
doesn't.
But actually, once you understand that and you see how that works in your body, then it unlocks the key to everything else.
Exactly.
So I think it is really important. We are only talking, let's be really clear, on type 2 diabetes,
We
not
are.
type 1. So if
Yes.
you are type
Very.
1 diabetic, it's a totally different disease. You
Yeah.
have
Yeah.
no ability to make insulin in your body, and therefore you need to replenish
Yeah.
it.
So you don't get insulin
So you
resistant
don't get
until
insulin resistant till
a
much
long
later on in
time
the
later.
disease. Yeah.
Yeah.
So we're only talking about type
Yeah.
2, which is a disease of insulin resistance.
Exactly. As are quite a lot of other metabolic diseases. There's an
Mm,
umbrella of metabolic disease
mm,
process or whatever you want to call it that underpins all of this. So diabetes is actually one little spoke on that. And that was the sort of revelation for us. And it
mm.
seems a long time ago, and it probably is quite a long time ago now,
Let's not
that
talk about that.
yeah, that the two of us began to question conventional wisdom when it came to treating chronic disease. We were at different stages of our careers, different professional backgrounds, but we were asking those same questions about the efficacy of conventional wisdom around treating chronic disease, particularly for patients with diabetes.
Mm.
And I know you knew it scientifically, but I remember you saying, but you realized that actually it hadn't been translated into clinical
Yeah,
practice,
yeah,
which was slightly bemusing to you.
yeah, yeah. It was really
So,
weird because when we looked at some of the drugs like metformin,
yeah,
we could see the mechanism of action and how it worked, but
yeah,
we didn't kind of make the next step and say, okay, so this is what
yeah.
metformin is doing. Therefore, we need to do this for everybody. It just didn't carry
No, there
on.
wasn't a hookup. So this
No.
is what's quite interesting, and it's not unusual for things to take a very long time to translate into clinical practice. So
Yeah,
if you look
yeah.
back at insulin resistance, I mean, it goes back a long way in terms of science,
Mm.
but nobody took much notice of it because they were so focused on just getting people's blood sugars down because
Yeah,
high blood sugars were the reason that people got complications. But we'll go
yeah,
back a bit. So
yeah.
do you think you were quite an unconventional pharmacist in the sense that you actually thought, what goes on here?
So at the time, I didn't think that I was. But looking back and
Yeah,
talking to other people now, I think, oh, actually, I think I was. I
yeah,
thought about it slightly differently. So not that I was a trailblazer by any means, and I
no,
didn't like start any movements or any
yeah,
kind of
yeah,
changes, but I did think differently, and I always kind of wondered to myself more than anything
yes,
else, why
yes,
are we doing this?
yes. How
And
does this work?
how does it work?
Yeah,
Yeah.
exactly. And I was a nurse practitioner in general practice, and I had a really good view, I suppose, because I looked after this group of patients.
Mm,
And I was also there at the time when they really started to standardize practice, and there
mm.
was all the business with QOF and how we were paid.
Yeah,
So
yeah, yeah.
there were good and bad things about QOF, but
Yes.
there's always good and bad things about everything. But there was much more protocoled care,
Yes.
and a few things began to sort of worry me. One was that we treated obesity in a very odd way. We saw it as an individual lifestyle choice
Yep.
and entirely the responsibility of the patient. We
Mm,
sort of ignored the strong family histories that were around in patients with type 2 diabetes, although, I mean, we did log them, but lots of people knew that they had relatives who'd, I don't know, lost their legs or their sight, but
yeah.
hadn't been diagnosed with type 2 diabetes. But of course, if you look back in most people's histories, there will be some genetic trail.
It's interesting actually how many people still tell me, which is I find it's fascinating.
Yeah.
Yes, I have a family history of diabetes, or I don't think I have, but I remember that my mother, this is
Yes.
usually what happens. My
Yes.
mother, when she was very close to the end of her life, was told
Yes.
she was diabetic, but they didn't do anything about it. It was just
Yes.
managed by diet and it never seemed to cause any problems. And that
Yeah.
really
Yeah.
resonates with me because
Well,
my
alarm bells
grandmother,
are ringing because you think, I wonder the metabolically how well that person was,
yeah,
in the 20 years that preceded that.
but my grandmother had type 2 diabetes that came on in her later life.
Okay.
And she didn't get any treatment because she
No?
also had Alzheimer's disease.
Okay.
But I
Yeah.
think when, looking at the
Yeah,
links
yeah.
between all of the things,
Yes,
I mean,
she might well have got
yeah.
Alzheimer's because of her metabolic problems.
And
Yeah.
interestingly, there was no, I mean, at that time, there was no question of any kind of connection.
No.
But she was not overweight. She was
Yeah.
I mean, she was probably what we call above her personal fat threshold
Okay. But not overweight,
in terms of
overweight.
where she carried
Yeah.
her weight, but not overweight,
Yeah.
overweight. So,
Yeah.
yeah, it really interests me when people say that because they kind of sanitize the effects of diabetes. And just because somebody was very close to the end of their life, it's not
Yes.
serious enough to take
Well,
seriously or
when
treat.
I joined general practice, which was a long time ago, it was definitely type 2 diabetes was of the elderly and not
Yes.
really, they called it mild diabetes. There was all sorts of terms for it. It wasn't taken seriously. But the other thing that began to worry me was the drug treatments that I was using seemed to be making people gain more weight. And
Yeah.
I started to think this is very counterproductive somehow, but also so depressing for them,
Yeah.
particularly when it came to insulin. And there was
Mm.
very little interest in general shown by clinicians in modifying dietary intake of sugars and carbohydrates,
I don't think they
which
knew what to advise, did they?
just
No.
seemed odd to me. But the guidelines were saying all meals should be based on carbohydrates. So this was all very confusing to me. And, I did start to think, I don't think I'm doing the best I can for my patients, which is
Yeah.
where it all began.
And I think the issue that we also had was, you know, we didn't have good dietary guidelines, that we didn't understand
No,
nutrition to the extent that I mean,
no.
I'm not saying we're perfect now, we are not. But
But we didn't even understand the carbohydrates. Well, we did, but we didn't.
so but
Made sugar, you
yeah,
know.
well this is the thing. I remember sitting in biology in year
Yeah,
7
Yeah.
finding out the structure of a carbohydrate. So I knew
Yes.
it was made up of sugars, but
But it
we never
wasn't
made that.
translated either, was it?
No, not at all. So
They
that
said,
was interesting.
have 2 slices of bread or whatever, and I remember thinking, "Oh, how does this work if that's glucose?" So
So
that was
anyway,
one of
yeah,
the keys, wasn't it?
that was one of the key things. So we just lowered blood sugars with any means possible, with
Yeah.
medications that often pushed people far too low and gave them complications of not having enough
Yeah,
sugar,
yeah. And made them put on weight because they had to eat.
and therefore made them put on weight because they had to eat. And
Yeah.
then we then ended up putting everybody who couldn't be controlled by that means and got sicker and sicker on insulin, which in
Which had
itself
even more
had
problems.
more weight gain and complications and
Yeah,
concerns
yeah,
and that.
yeah,
So
yeah.
we knew about insulin resistance, but we didn't work it out until
It
much,
was
much later.
yeah, it was basically not used in clinical practice. So we were just told that the lower you could get people's sugars, the better for
Yeah.
complication rate. I get that. But the way we were doing it was actually feeding into the problem. And what we didn't know was that these patients were actually trying to compensate and make more insulin to cover their high sugars.
Mm.
So your body's always got a plan B
Yeah.
generally. And this was the plan B, that instead of depleting your insulin from those beta cells in the pancreas, it was producing more and more insulin to try to sort the problem. But you were less
Yeah.
sensitive to the
To it.
insulin you were producing. And this was, to me, the absolute, missing puzzle piece. I suddenly thought, oh, I see it all. Because
Mm.
when you've got high insulin levels, you're very you're very hungry
Hmm.
because you have to be hungry to
Counteract the
balance the
effects of the
book
insulin.
to balance the books, yes. And also, insulin in itself is a fabulous fat storer. So
Yes.
you're actually we're giving patients drugs that increase their hunger and make them very efficient fat storers,
Yeah.
but
So we
yet
have to
we
remember that the way insulin works is it so obviously the primary role of insulin is to make sure that your blood sugar doesn't go too high, because if you have too high glucose
uh,
in your bloodstream, then it causes nerve damage
yes,
and
the
allows
damage, yeah.
infections to proliferate and
No,
all
I
sorts of other
understood
things.
that.
So that was that. But insulin, as it is released, pushes glucose into the cells of the body to be used as energy. That's how it works. So it takes it from
Yes,
the bloodstream and it pushes
yes.
it into cells. But if you have too much and you can't burn it off, for example, you've eaten a massive piece of cake and then you sit on the
It'll
sofa,
store it.
then it
Yeah,
just goes, okay, so you don't need this right now. I'm
so
going to
we'll
keep it for
store it.
later. And then it
Exactly.
puts it into fat cells. And
Whereas,
it,
we were taught that in fact the sugars weren't getting into the cells.
yeah, but it's not the case.
No.
It's just that it's saying, okay, this, you don't need this right now. I'll save it for later. So it's an
Yeah.
incredibly good, if you like, if you think about it in some terms, it's like a savings
Well,
account. It's
exactly.
great at saving
Exactly.
for a rainy day. But the
Except it
trouble is
wasn't a
that
rainy day.
there's no rainy
Yeah,
days. Yeah.
exactly. And we were told to tell patients they'd be on insulin in 2 years from diagnosis, which
Oof,
I think, looking back, was
oof, harsh.
incredibly depressing thing
That's
to
really,
tell
really soon.
people. And not only that, they were going to put on a lot of weight. I mean, I don't know what all of this made me start to read, and I think understanding insulin resistance was the key to all the rest of my interest, really,
Mm, mm,
because I
yeah.
began to think this isn't so simple, is it? It's not just about depletion of insulin.
No,
This is
no.
much more complicated.
Yeah. Yeah. So once you realize that actually it's not about what you have done so much, but how your body is responding to the way that you're living,
Yeah.
you can start to make a few changes. And that allows your sensitivity to increase. Because the best part of this whole story is actually
Yes.
that it's reversible,
Yes. And we didn't
which we
know
never,
that.
never knew.
Nobody knew that. And I think
No.
that was and I don't know whether people all still know that, but you can resensitize your system. And it's
Mm,
easier in some people than others, and it'll depend how long you've had diabetes, and it'll depend on lots of other things because
mm,
diabetes is only one tiny spoke in that metabolic
Mm.
syndrome. Do you remember Syndrome X?
Oh, yes, I remember Syndrome X.
I remember being fascinated by Syndrome X, and that was part of that. I see this might be part of a bigger picture rather
Mm.
than just about sugars. So they
Mm.
talked about lipids, blood pressures, and the banner of metabolic health started to sort of appear.
Mm.
And then you understood that actually blood sugars was only the end point of one of those spokes. And that was
Mm.
also incredibly enlightening because we were just allowing people to become diabetic.
Yeah,
We were basically looking at them and we were watching their sugars increase. HbA1cs, by the way, made all the difference as well. Because
that's true.
before that
Yes.
we only had sort of fasting sugars or blood sugars done on the spot.
Mm.
We didn't have anything that gave us a clue that somebody might have overall higher blood sugars. So the HbA1c was also key to all of this.
Mm.
Um, but, that was the insulin resistance, if you understand it, really was the missing piece of the jigsaw.
Yeah.
And it's why medications started to change slightly.
Yes.
And also we had a lot of problems with older people and hypoglycemia. So giving people medications that are quite, what's the word, rudimentary in terms of making more insulin
Mm.
was quite a dangerous business
Yeah.
because people started to get hypoglycemia because we were
Yeah.
trying desperately to get blood sugar levels down now.
Mm. Mm.
There was all the complications of that as well, which was hugely dequalifying of people's quality of life when you think about it, because
Well,
they lost
yeah.
confidence hugely when they
Well, you can't go
thought,
out and about if you might think you're
"No,
going to have a hypo in
exactly,
Tesco, can you? Yeah.
exactly." Again, we ignored all that, but I think for patients, that was a real thing. And of course, people then just don't take the tablets.
Yeah. Yeah. And that's the same as, do you remember when we used to give people diuretics as first line treatment for high blood pressure? And then the little old ladies would come to
Yeah,
you and say, well, I don't take them on Tuesdays
yeah,
because on
because I can't,
Tuesdays
I've got to
I
go
have
to
to
the
go
market.
shopping
Yeah.
and I can't, there's
And
nowhere to
you
go to the
thought,
loo.
not sure how this is working for them. Yeah.
Yeah, yeah. I tell you, the most fascinating thing though about insulin resistance that I still think is
Yeah. Yeah.
understood,
Talked about. Yeah.
yeah, is the fact that when you're pregnant, your body naturally becomes more insulin resistant
Yes.
because it
Yeah.
wants you to put on weight to make the fat cells that you then break down to use as
Yes.
energy for milk when you have your baby. So
Interesting.
this is,
Yeah.
I find this fascinating. But
Yeah.
so
Your
being
body's so
pregnant,
clever.
isn't it? Being pregnant is a natural insulin resistance story
Yeah.
because obviously, again, as well, you need more energy so that your baby can grow um, in
Yep.
utero. So it
Yeah.
all kind of makes sense when you think about it. And then
Yeah. Yeah.
also, people who have polycystic ovaries syndrome are more insulin resistant.
Yes.
Again,
Yes.
it's not just about, it's not a terrible thing that has
No.
happened because the design of
No.
our body is flawed. It's
No.
good
It's
because
just
you
being
can see that
used, yeah,
there's a
the
real
wrong way
reason for it.
because exactly. But of course, we live in a world full of food and we are grazing rather than eating meals. There's so many factors here.
And
Activity
there's
levels
so
have
much more,
dropped.
yeah, there's so much more to it emotionally and mentally than just
Yes.
physical hunger as
Yes.
well. People are hungry for many, many different reasons. And I
And
think,
remember, the dietary guidelines at the time were terrible, weren't they? Because, well,
well,
I think they
yeah,
probably still are, I don't know.
I don't think they've actually been updated. I think
No, I mean,
they continue
basically,
to be.
people were eating mostly carbohydrates. I wouldn't,
Mm,
we won't go into that now, but I think we didn't really understand that either. And that bowl of cereal with orange juice, toast, and marmalade, which is what honestly most of my patients had for
yeah,
breakfast.
yeah,
And then they got that huge peak in blood sugars and
yeah.
subsequent crash. And they had high levels of mid morning hunger, funnily enough,
Funny that, yeah.
because of the insulin levels, but we didn't understand that. And
But
when
the
you
other thing
changed
is,
that breakfast, people went, "Oh, I see."
yeah, yeah. And the worst thing was that we were all doing much more sedentary jobs. So we would have that big
Yes.
intake of
But we were
sugars,
at a computer somewhere.
sit at a computer, and then wonder why
Yeah.
2 hours later we were starving. Then we would
Yes.
have to kind of, you play the game of, can I wait till lunch or shall I have some of the office
And that
cake?
was even us, and that was
Oh,
with
yeah.
normal metabolism.
Yeah.
So Goodness knows what it did to people who were already insulin resistant.
Yeah, yeah.
But it's very easy
So,
to get insulin resistant if you eat like that forever. So, however healthy you might be,
mm,
it will catch up with you eventually.
it
Um,
does.
and insulin resistance is really the key to understanding almost all the chronic diseases. And they're now linking, as you say, Alzheimer's, which we
Hmm.
never dreamt about. But
Mm.
metabolic health is really the business.
It really is, isn't it? I think that's why I enjoy it so much because
Yes.
it's just about there's so many links to other diseases. There's
Yes.
so many things that actually, when you come back down to brass tacks, eating well and looking after yourself well
Yeah.
is
Yeah.
actually so important for overall health. And it
For
doesn't
everything.
mean, and this is
Yeah.
the thing I think is really important, it doesn't mean we all have to be stick thin. It
No, no,
just
no. It's
means
not
that
about
we,
weight
yeah,
particularly. It's
but I
certainly
think
not
we've got,
about BMI.
no, we've got really confused with that.
Yes, very confused. I
And I think
agree.
there is another part of the story that we do need to talk about, which is when we want to reverse things, how is the best way to do that?
Yeah,
And
yeah.
does calorie counting come into it, or is it all
Yes.
about
Okay.
quality and quantity? And there's a lot to unpack there. But
Yeah.
yeah,
I look back and I think I'm completely averse to calorie counting
yeah,
because it doesn't explain the picture properly. I mean, calorie counting is really not
I
that useful
it's
in the
not.
long term.
It's not in the long term, and I wonder in the short term
Yeah,
if it
yeah,
gives
yeah, yeah.
enough of a shock to kind of
Yes,
start the
yes.
ball rolling.
Well, you would know more because you're, practicing and
Well, with total diet replacement, which I do on a couple of
yes,
programs,
which
it
is a
does.
very interesting sort of
Yeah,
way to do it. This is the shock way,
it
really.
is the shockwave. That's where the evidence that we first
Yeah.
got from Professor Roy Taylor for reversing
Yes.
diabetes came
Yeah.
from and
Of
still is
course. Yeah.
useful. And it does work. And I wonder whether or not it's just because when we get to a certain point,
Yeah.
that is the only thing that can reset the balance.
Well, that is a good question. Or do you think if you modified those lifestyles and then just look to the long term, you could still get to the same place? I mean,
And I wonder,
I'm really
yeah.
interested in that, and also whether the sustainability would be easier. I mean,
So
I'm more
I
interested
don't
in
know. Yeah.
sustainability.
I think that's a really interesting point because I don't know, but is it part of the attraction and the motivation and the help for the people who really need it that
Yes.
they get that quick
Well, that would
fix?
be one argument on that side of the coin is that
Yeah.
unless you motivate people, all discussions are academic.
Because
I mean,
actually, if
yeah,
you're only losing 2 pounds
in a month.
in a
Yeah,
month, are
yeah.
you actually going to stick with this because you can't see the results? So,
Yes,
calorie
I
counting,
agree.
good or bad, actually, if we can get you
We
to lose 10
we could have a
kilos,
we could have
mm,
a good debate about it, but I agree
yeah,
you have to get people on board because
yeah,
if you don't, we're just talking about it. We're not going to help
yeah,
people. So
yeah.
you are helping people, but I'm still wary of the long term. And the
So,
same goes
yeah.
for the weight loss drugs, and we'll talk about
Yeah,
them next
and
time.
I think it is all about I've decided, and
Right.
I may be wrong, and I'm gonna
Yeah,
probably eat my words in a
yeah,
few months,
yeah, yeah,
but I honestly think it's down to the support and the long-term
yeah,
guidance, actually, more than what you do.
yeah.
And if you can
Mm,
get somebody to come with you and say, "Let's try this, and this is normal, and
yes,
let's do this, and now you must do this."
which is why our jobs were so incredibly satisfying, and yours still
Yeah,
is, but I'm
yeah,
no longer practicing. But the absolute, joy of seeing somebody start to believe in themselves and start
mm,
to feel that they have some control over their health, it's
yeah.
very addictive.
Oh, yeah, definitely, yeah.
And unfortunately, there is just not enough access, I suspect, and it's very expensive. So what do we do? How do we do this better? And by the way, Channel 4 tonight
Oh, is that?
at 8 o'clock, there's a program with our Dr. Chatterjee.
I saw him this morning talking about over medication. Is that what he's on about?
Yes, yes, and
That sounds right up my alley.
yes, interesting program for us. And he takes diabetes as one of those strands of over medicalization. So,
Do you think I can
um,
count that as CPD? Probably not.
I think you can. I think you can. I'll be interested to see because we want more people to be aware,
Yeah,
and a TV program like that might be a really
might be
good way.
helpful.
Of course, you're always talking to the converted in some sense,
Yeah.
but still, that's
I think
giving it
actually, interestingly enough, the thing that he probably, and I don't know what he's going to say, so who knows,
no,
but most people
or
that
we
I've
sort of do.
spoken
Yeah.
to in my life have said, don't want to take medication.
No, that's interesting, and actually, you can use that, and I
Yeah.
agree. You can use that by saying, "Okay, but I've got alternatives, but you're gonna have to buy into that.
Yeah.
You
And
can't
also, it's a little bit
do
harder work.
neither. Can't do neither." Yes,
Yeah.
exactly.
So,
Interesting.
yeah, I think it will be interesting. But yes,
Well,
the
for those in the
skepticism about that.
UK, have a
Yeah, it's
listen.
called Live Well with the Drug Free Doctor.
Yeah, and I think you'll find some nuggets there that we have talked about over the past 2
Mm,
years.
mm. I think, hopefully as well, he's gonna. I mean, I haven't watched it yet, so let's maybe do a recap on when we do watch
Yes.
it.
Okay, well,
But
we'll talk about it when we come back,
yeah, yeah,
and then talk about reversing metabolic disease,
disease. Yeah,
prevention of some of this, and how those weight loss drugs work
I think if we,
into this.
yeah, yeah, because they have a role,
They do.
but
Well, they're
what's
part of this
they're
process
part
of
of the story,
reversal. Yeah.
and I actually think now that we've got these weight loss drugs, and there's an oral one being developed or has been
Yes, I
developed in
see
China.
that. Yeah.
Um, but
That'll
this is not
change
the end.
everything.
This
Yeah.
is not the end of the story for any of these things, and there's going to be
No,
more, and they're going
no,
to
of
do more
course.
things.
Yes, of course. But we're on a very different tack to where we started, and that was the point of today's podcast, really.
Yes.
Where we started was all about just decreasing abnormal sugars. And we're so much further down the line now in terms of
Yeah.
our understanding. And these weight loss drugs are part of that new understanding. So, not all bad, not all good, as ever.
Yeah. Interesting.
All right.
Cool.
Good to
Thank
talk to you.
See you later.
See you next time. Bye
Bye.
for now.